In terms of the first part, is the federal government going to change it? I think there are currently some bills in Congress that would seek to add more sociodemographic information to this and to adjust for that. What the status of those bills might be in Congress is, kind of hard to ascertain at this time. But I think
so not very good then.
But I think there is more concern as hospitals and hospital associations and other groups begin to say, look, this isn't working the way we thought it was going to work. In terms of your second question about California in particular, California is one of the 14 states where more than 50% of the hospitals are penalized. In the most recent data of the 283 California hospitals that are assessed, some hospitals are exempt from the readmissions program for various reasons. 52% of the hospitals had greater penalties, 48% of the hospitals had greater bonuses, and 1% of the hospitals broke even in some way. So, but California is in that portion of states where the penalties outnumber the bonuses.
And what do you attribute that to? Is that because we have higher areas of diversity and more areas of need than say other states, or what's the reason?
It's hard to know, what the specific reasons are for that, but one would think that the great diversity in this state and the large number of patients and being treated, the size of the hospitals, the size of the emergency rooms are all a big factor in that.
Okay, thank you. Let me just thank both of you for your time this afternoon. I appreciate it. We're going to now move on to item number 4, disparities in the era of data. We have presenters Sarah Brooks, Managed Care Quality and Monitoring Division Chair, Department of Healthcare Services. My understanding is Marie Cantwell will not be here. Jamal Miller, MHA Deputy Director, Office of Health Equity, Department of Public Health. Peter Lee, Executive of Cover California. You were able to make it on time? Appreciate it, and we would have made accommodation for you because I understand you might have been running a little late. David Lone, MD, Chief Medical Officer, Safety Net Institute. Robert Moore, MD, Chief Medical Officer, Partnership Health Plan of California. Good afternoon and welcome, and please proceed. We'll start off with Sarah Brooks.
All right, good afternoon. I'm Sarah Brooks with the Department of Healthcare Services. I'm the Chief of the Managed Care Quality and Monitoring Division. Thank you so much for the opportunity to speak with you today. So wanted to just start off a little bit and provide, thank you. Wanted to just start off and provide a little bit of context and information about some of the work that the department is doing today. Addressing healthcare disparities is a key goal and priority for the department, especially given, as Senator Hernandez said, the department is now providing care to 1 in 3 Californians. The DHCS quality strategy for improvement in healthcare, which is modeled after the national quality strategy, does provide operational detail. It outlines implementation activities in clinical and population health areas, which includes specific activities under the priority area, eliminate health disparities. To accomplish positive outcomes in population health initiatives, DHCS works across divisions, with other departments such as public health and social services, with national groups such as the Robert Wood Johnson Foundation, with stakeholder groups such as the California Healthcare Foundation and CPEN to work to ameliorate issues around healthcare disparities. In the various clinical and population health initiatives in which DHCS is engaged in today, for example, the Million Hearts Initiative, the Asthma Management Initiative as well, we work to incorporate efforts focused on reducing health disparities. Many of you know about our waiver renewal, which is now called Medi-Cal 2020. We are including many new initiatives to better integrate and coordinate care for the full spectrum of care settings in the waiver renewal proposal that you will see soon. These initiatives include new partnerships and realigned financial incentives between providers and plans, and between the plans and the state. These initiatives provide an opportunity to focus on health equity to ensure that our most vulnerable populations are receiving appropriate care. This is one of our primary objectives for Medi-Cal 2020, and we're asking for $15 to $20 billion from the federal government to invest in these programs in a meaningful way over the next 5 years. We will focus on health equity as a key component of the coordination we are requiring between plans and providers. We know that high utilizers with multiple chronic conditions, much of what we heard earlier today in the discussion that happened today, individuals experiencing homelessness and those with serious mental illnesses are more likely to overutilize emergency rooms and underutilize primary and preventative care. By realigning financial incentives for the plans and providers to ensure that these beneficiaries are receiving appropriate levels of care while requiring and monitoring the plan's performance on quality metrics, we will improve the health outcomes for the hardest to reach populations. In this and other waiver programs, we will work to stratify the data by race, ethnicity, language, and other demographic factors to ensure that quality metrics are met across populations. So as I said, I'm the Managed Care Quality and Monitoring Chief, so I wanted to talk a little bit about some of our activities today. DHCS has already started stratifying HEDIS measures by different demographic factors. That includes race, ethnicity, language, gender, geographic region, and other factors as well. For example, DHCS did look at the HEDIS data related to postpartum visits. We did identify that there is an overprevalence of Black women that are not receiving postpartum visits. As a result of that, we did set that as a key quality improvement goal in our managed care quality strategy and included a threshold that we'd like to reach over the next couple of years. We also have convened a work group of our managed care plans to talk about best practices and how to ameliorate that issue. Beginning in state fiscal year 15-16, so later this year, DHCS will stratify all HEDIS measures with a few exceptions, and we can talk about those if you'd like, by different demographic factors. So we look forward to having that information and utilizing that in providing care to our beneficiaries. You also may be aware of the fact that DHCS has been engaged in an encounter data cleanup over the last couple of years. We did implement the Encounter Data Improvement Project about 2 years ago, and that does look at improving the completeness, accuracy, reasonability, and timeliness of the data. This is key and is important because it's allowed us to come up with a data set for encounter data for our managed care plans that we're now able to utilize to analyze health outcomes, quality metrics, and stratify that information by demographic factor. As you know, stratification of health plan data in general allows the department to focus quality improvement efforts to meet the needs of a subset in the managed care population, while at the same time reducing health disparities. Finally, I wanted to talk a little bit about grievances and appeals data. So this data is reported to us quarterly by our health plans, and through recent standardization, we now actually receive information that is by beneficiary. That allows us to stratify that data and look at what's happening by different demographic factors. So we might be able to look in a specific geographic region. We also could look at a certain race or ethnicity, age, gender, but really diving down and looking at, for example, is a certain group of African Americans in a certain regional area not getting transportation services. So really allows us to identify where are the issues and how can we work with the plans. So then what do we do with that information? We look at that information and really trend across plans. So we're looking to see, is this a specific issue with one plan? Is it happening with a lot of plans? Regardless, we provide technical assistance to the plan or plans after we identify the issue. In terms of next steps, which I'm sure you all would be interested in, if the plan does not come into compliance with the issue based on the technical assistance that we provide, we do impose a corrective action plan that does include specific milestones and also timelines for meeting those milestones. If the plan then for some reason would not come into compliance with that CAP or corrective action plan, then the DHCS can impose sanctions and or penalties. So those are my speaking points for today. I really appreciate the opportunity. Thank you so much.
Thank you. Go on to the next presenter.
Clicker, please.
Jamal Miller.
Great. Good afternoon to Chairman Senator Hernandez, as well as to Assembly Member Bonta. I appreciate this opportunity to share on behalf of California Department of Public Health's Office of Health Equity. Excuse my back to those who are behind me, but I wanted to have at least this perspective to share today's presentation with you. I call this slide the stair steps, and unfortunately these aren't the stair steps to heaven, if you will. When you look at the disparity between African Americans and Asian Americans, 86.1 in life expectancy, and African Americans 73.3, I often expound upon this need to really disaggregate once again, and I'm glad that those who have spoken prior to me have highlighted really the need to disaggregate that Asian American component. And oftentimes what we found out of the Office of Health Equity and within the California Department of Public Health is when we look at the array of data resources to pull together numbers like this, there's a lack of standardization. So we share that interest in having a more standardized approach across the array of data sets out there so we can report in a more accurate way about disparities and inequities here in California. The highlight on this slide is particularly at the bottom, however, that an Asian American baby born today in California is expected to outlive an African American baby born the same day by more than 11 years. And our objective, within one of the objectives that we have in the Office of Health Equity, is we literally want to get flat. We want to flatten maps and data like this so that we can show how our state is moving forward to achieve health equity. An important part of the data discussion that often lacks is the economic implication of health inequalities across our country and particularly within the state of California. This study that I cite today, commissioned by the Joint Center for Political and Economic Studies, highlights between the years of 2003 and 2006 that the combined costs of health inequalities and premature death were $1.24 trillion. That's direct and indirect costs. But when you look specifically at the opportunity associated with eliminating health disparities for minorities, that would have reduced during that same period of time direct medical care expenditures by approximately $230 billion. And if you give or take a few million or even $1 billion here, this number and these numbers are still fairly high, and it just shows us the economic implications of premature death. And I think it's really important that we take in the economic implications and the growth model implications of why achieving health equity is advantageous for the state of California. We've talked earlier about income security as a key social determinant of health. In the next two slides, I want to highlight what this looks like, because when we look at the demographic comparison and see the uneven distribution of household wealth across racial and ethnic groups in California, we see that demographically there is a huge difference when we compare those households and the wealth that they are responsible for. So if we highlight African Americans in their households represent 6% of California households, but hold about 2% of household wealth. And particularly within our culture in America, having income security plays a key role in your ability to access the resources and the amenities that are associated with having a higher quality of life and as a byproduct, an increased life expectancy. And to expound further on the role of income security, we often have talked about changing institutions and systems by addressing social determinants of health and going upstream in our systems and institutions. But I would contend that we also need to go upstream in the life course and look at how economic disparities impact our infants, our babies, even prior to when they're born. And this study that I highlight today, according to research coming out of the University of Colorado at Denver, women who are poor experience higher cortisol levels in pregnancy and give birth to infants with elevated levels of stress, of the stress hormone. And we all know that this heightens the risk of developing serious disease later in life. If we look specifically around the epigenetic dynamic here, the study, and it was published in the American Journal of Human Biology, is that this is the first study that measures cortisol level in infants and relates it directly to the socioeconomic status of the mothers during pregnancy. And this is really, really important when we think about the broader determinants of equity or the social determinants of health, that beyond just the doctor and the hospital, it's very critical that we have care and coverage, but even beyond that, there's this 90% dynamic inclusive of income security that's playing out in the lives of our babies even before they're born. And having a nurturing environment for our children and for our mothers is key to addressing this issue. So addressing the broader social determinants of health is key if we want to transform the conditions in which people are born, grow, live, work, and age. And uniquely, each of these social determinants that we have listed here, it intersects uniquely. If we're going to have healthy people If we're going to have healthy communities that come from healthy environments that come from healthy societies, we have to seriously consider from a budgetary standpoint, from a policy-making standpoint, how we each respectively across all the branches have a role and responsibility to affect the social determinants of health and how they intersect with people, communities, environments, and healthy society. For the sake of time, I'm going to skip this slide in particular. I come today kind of partially with a solution. It's not the ultimate, solution to the problem that we're talking about, because there are so many dependencies that we have across private and public sector to achieve the challenges we have in data. But I'm glad to highlight today our Healthy Community Data Indicator Project, which is affiliated with the Health in All Policies Task Force. And I have the honor of leading a team that staffs the Health in All Policies Task Force, and it's affiliated with the Strategic Growth Council. A part of that work that got underway about 3 to 4 years ago, more than 4 years ago, was an assessment and evaluation with local health departments as well as with the 22 task force members for health and all policies. And the question was literally asked, what makes a healthy community? And when we think about the data and the information that's needed to define how we can meet the basic needs for all, how we can have a community or society that addresses quality and sustainability, a society that addresses health and social equity, a society that addresses social relationships that are supportive and respectful, and then adequate levels of economic and social development. Understanding that these are highlights of what make a healthy community, but understanding that there is a lack, based on the feedback that we received a few years ago, there's a lack of a cohesive data resource to provide that information, particularly to local health departments around planning efforts. So in response to those findings, the Healthy Community Data and Indicator Project was initiated, and we have the privilege of having that team work out of the Office of Health Equity within the California Department of Public Health. And the intent of this project is to enhance public health by providing data, a standardized set of statistical measures and tools that a broad array of sectors can use for planning healthy communities and evaluating the impact of plans, projects, policy, and environmental changes on communities across the state. And we're proud to say that many local communities, both from a private and from a public perspective, they've used many of the indicators that have come out of our Healthy Community Data and Indicator Project to do community health needs assessment, to make general plan updates. And even though this project is not complete, we'll ultimately have 60 indicators when it's done. We have well over 20 completed now. It's already been shown to be of great value at a state level as well as at the local community level. The difference in this data resource is that it focuses particularly on 2 areas: health and the factors that influence health in the built and natural and social environments, and then health and social equity. So we're looking through a health and a health equity lens and creating this Healthy Data Community and Indicator Project. As I stated before, we have just under actually 60 indicators broken out by those areas of interest as to what defines and makes up a healthy community. And to give you some graphic examples, here's one highlight from our Healthy Community Indicator How-To Manual, which we produced towards the end of last year. And this gives you a place-based example, particularly in Alameda County. And we see a white child from the Oakland Hills can expect to live 85 years, whereas an African-American child living in West Oakland, just a few miles away in close proximity, can expect to live only 70 years. And each of the bullet points that you see with regard to a child from West Oakland and then as an adult, each of those bullet points is data or information that's come out of our Healthy Community Data and Indicator Project, publicly available. And even though it's not fully completed, we're glad that we have this resource to be able to share with all. And we have, consistent with the theme today, run into some barriers and challenges when we look across the array of data resources that we pulled from and that we've synthesized. So we share, once again, that commitment to try and find a way with respect to standardization and disaggregation. Some quick examples I want to share, ways in which the Healthy Community Data and Indicator Project shares information. So from a county perspective, on the left-hand side, we see the average cost of a market basket of food, of nutrition, The hot spots in particular, the red spots, is not necessarily good, and it shows that those particular communities are sharing a higher income burden when they're investing in to the nutrition and dietary decisions of their families. From a census tract perspective, because it's not always the best approach to pull data from a zip code perspective, even though many data resources out there are aligned and arrayed by zip code. Census tract is another example by which we pull data. And this one on the right is a percentage of households paying in excess of 50% of monthly household income on housing costs. And this ties, once again, not to the traditional health statistic, but it ties to income security, which plays a critical part in our ability to live a longer life and a higher quality life. On the left side, you see from an environmental quality, climate resilience perspective, the darkest components on the left, it shows non-white or Hispanic Latino population. And then on the right side, you see that it almost perfectly coincides. There's a positive correlation, unfortunately, when we see the pollution burden of California. And this is another example of how our data project has been helpful in visually seeing where many of these disparities and inequities exist here in our state of California. Once again, an example, access to public transportation from a city perspective. And the hotspots in this instance highlights the percentage of residents within a half mile or a major transit stop. So the darker or the redder means that the access to public transit is far more challenging. And just giving you some examples, but also trying to enlighten all of us, including myself, around where many of these social determinant of health challenges and opportunities are. Time series is another way for us to look at data, and we think about neighborhood safety and efficacy. Here's another example. And then using the Gini coefficient to understand the distribution of household income relative to the number of households. So if you look as a descriptor, the lower the number is, there's a lower inequality when we think about how income is distributed across various communities. The higher the number is, there's higher inequality, thinking once again about the distribution of household income relative to the number of households. So this is information that we have access to within our office. We share the concern once again, and we often hit those roadblocks around if we want to disaggregate information and dig a little bit more deeply into where many of these social inequalities are that lead to disparities and inequities, it's something that we constantly are up against as well. So I applaud and appreciate the commitment of this committee, and we plan to go upstream in having a more standardized approach and having data more readily available that allows us to address living conditions, institutional inequities, as well as social inequities. So thank you so much for this time.
Thank you very much. We'll move on to Mr. Lee, Executive Director, Covered California.
Senator Hernandez, Senator Bonta, members, great to be with you today. And thank you for hosting this hearing. I think it's a very, very important one. It's timely, given that Covered California just weeks ago wrapped up our second ever open enrollment period. And as you know, addressing health disparities is central to our mission. It's actually written in our mission statement. It was from 3 years ago. And I'll fly by it, but it is important when we think about what we're about. It's not just about getting people in the door and giving them a card, getting them a coverage card. It's getting them access to care. So what I'm going to run through very quickly to have an opportunity for questions is, so 3 elements is update you on the open enrollment period, because a starting point for us is to get people that card. Second, though, is make sure they understand how to use that insurance, is make sure they're educated about health insurance. And finally, to hold our health plans to account, to make sure that they are addressing everyone in our diverse state and our very diverse enrollment. So that's what I'm going to run through very quickly. Okay? So again, our mission statement bakes in specifically that we're about the triple aim, and you heard about this earlier panel, the triple aim, though, with a focus on reduced health disparities. Yes, we want to have better health, better care being delivered, and reduced costs. But if we aren't looking through a lens of health disparities and health equity, we aren't looking at California. So that's been central from day one. So how have we done in our most recent open enrollment period? Well, first, we enrolled a lot more people, about 500,000 people. We now have about 1.4 million Californians enrolled in Covered California. I think it's appropriate to be sitting next to representatives from Medi-Cal, DHCS. In this same period, about 800,000, more than 800,000 people newly joined Medi-Cal. on top of the 3 million that joined last year. So clearly, when we look at addressing health disparities, Medi-Cal, Covered California need to be partners in the incredible expansion we've seen in coverage. When we look at the ethnic mix of who is enrolled, a couple things I'd like to highlight. And this is comparing this year's open enrollment to last year. So this is the second time we've ever done an open enrollment period. And we saw real substantial improvements in a number of areas. First, and in particular, Latinos are 38% of those who are eligible for subsidies in California, and Covered California. They represented 37% of those enrolled, very close to the number of the subsidy eligible population, and a substantial improvement from last year when it was about 31%. African Americans are 5% of subsidy eligible. Last year we only enrolled about 3%. We increased that to 4%. Not all the way to 5%, but it's making substantial progress. Last year we did a very good job enrolling Asian Pacific Islanders. This year, it's about 19% of those enrolled compared to about 21% subsidy eligible. We're trying to figure out what's the story there. We continue to do a lot of outreach in those very diverse communities, but it's something we need to learn from and see, was that we did a better job last year? What's that mean? But the overall story here is a couple things. One, we think it's critical to have this data. We know that about a third of the people that sign up don't answer this question. And without having that answer, we can't do the analysis that everything is built on. And we're looking at who doesn't answer and why, how do we boost that response rate so we can use this data as we go forward. How do people get supported to enroll? And this is a really important issue. You heard earlier about the role of navigators. Navigators are very important for helping people enroll, but also to retain their coverage and understand how to use their coverage. That was about 10% of the people that enrolled this last year enrolled through navigators. 43% through certified licensed insurance agents. And we need to understand how did they serve individuals by different ethnic groups, different languages, et cetera. And for all of this data, we're in the process of going through deep analysis to look at, for instance, certified agents, how'd they do with Koreans, how'd they do with Vietnamese, how'd they do compared to navigators for Spanish speakers, et cetera. And so this is an element of where we're in the process of doing the analysis to see how do people get that leg up to understand how to enroll. With our open enrollment period, and I'm going to quickly move on for this, but we had strong enrollment, higher shares of Latino and African Americans, a younger mix, and we found that the support that we had through our service center and major investments there paid off. Expanded both Spanish speaking and a whole range of Asian languages on our service center staff that led to 13% of people signing up through that service center, but also helped people retain their coverage. So that's getting people the card. The next piece, though, well, actually, I have some background on some of the outreach we've done that I'm going to fly through in the interest of time, but we did a lot of things for improving language access, making sure we did outreach with immigration partners, because one of the concerns we've had from last year is the false impression that the information we needed on immigration status and mixed status families might deter people from signing up for coverage, both in Asian communities and in the Latino community. And we had a very good partnership with some of the leading immigration organizations to get the word out. That's not the case. I think that the enrollment we saw was helped by that. We had fact sheets, again, on that same issue, and enrollment support. And it's important to note when we think about who does enrollment, we have over 1,000 people answering the phone, but there's tens of thousands of people across California doing enrollment. 14,000 insurance agents, 6,000 certified enrollment counselors, county eligibility workers in every county that do enrollment, not just in Medi-Cal, but in Covered California. So that's sort of the opening of the door to get people into coverage. Once they're into coverage, though, we have a number of elements of our doing a welcome to say this is what health insurance is. It's increasingly important as this year, more and more of the people that signed up had never had health insurance before, and you know to this, Dr. Hernandez, it's folks that don't know what a deductible is, don't know what an out-of-pocket is, et cetera. And so helping people understand now that you're enrolled, and it's both our job, but it's also the health plan's job. And so we don't try to create a new booklet, a new 50-page book. It's rather making sure people know the basic terms of what is a premium, what's a copay, and making sure they know where to go to get started, to visit a doctor, to get the free preventive care that's available, to understand what their costs are. And so that's a core element that we have embarked on of using their plan, because again, getting the card's not enough. Third element, though, I'm going to go to is ensuring that consumers get quality care. And we do this in 2 tracks. One in our certification and selection process of our health plans. So we actually work closely with the health plans we select through a RFP process that asks them what do they do for access and timeliness standards by language. What do they do to provide culturally appropriate care, effective management of chronic conditions. And this is part of our recertification process we're just embarking on for 2016. It's part of the process for selecting plans that are part of our portfolio today. In doing that, we specifically ask our plans, the 10 plans we contract with, what they do in terms of collecting data on sexual orientation, in terms of what they do to collect data to match up services and assess in their enrolled populations, how are they doing? And again, these questions look at disability status, interpreter need, education, sexual orientation. The other big thing I'd flag is that we're now in our second year of providing care to now 1.4 million people. We are embarking on a major data initiative, and one of the themes here is getting data and analyzing it. We will be taking actual claims data from every one of our health plans all pooled together. So one of the questions you heard from Ignatius Bao was some of the things you can do with cloud-based and the question of all payer. We're a purchaser. We're a very active purchaser, like CalPERS, which takes all the data that they have across all of the CalPERS enrollees to say, how is Plan X versus Plan Y doing for serving diabetics? We'll be doing the same thing and have done a competitive RFP process. So we'll be having, not just in the clouds, but in one location, data on all of our members that we can then assess along with race, ethnicity, language, to see not just how our plan's doing relative to diabetics, but are they doing differently for Latino diabetics versus African American? Are they doing differently based on income level of those that are covered by Cover California? So this is a key element that we have going forward. It's going to be an ongoing process. We look forward to working with partners like we have here at this table and you've heard from before, because the issues of having the data, analyzing it, and then using that for accountability for the health plans we're contracting with, for the doctors, medical groups, and hospitals they contract with, I think is part of what our common agenda is.